Okay, well, good afternoon, everyone. Thank you all for taking time out of your schedule to join us today. Um, Today, I'm Donna. My name is Donna Walters, and who am I? I'm just a woman living here in Trinidad and Tobago from Jamaica. I have here today with me Dr. Pottinger. So I met Dr. Pottinger about 11 years ago, and I've learned so much from him. To the extent that I think that some of what I've learned, we need to share with others. So today I have Doc. We'll be talking, about women's health and a very important topic, cervical cancer, right? I think this topic is very important because oftentimes we don't want to speak about things related to women and our female parts. And, oftentimes we're often very afraid of going to do the checks that we need to do, right? So today we're going to have this very impactful conversation to talk on this topic. I'd like to welcome Dr. Anthony Pottinger. Right. So when I met Dr. Pottinger about 11 years ago, and he was recommended to me by my hairdresser. I'm not sure if she's on today, Shelley. And I remember, saying when I moved to Trinidad, I wanted to make sure I had doctors and so on that I could visit, doctors, dentists, etc. And I recall Shelley saying Dr. Pottinger is the best. And I think when I went to him, I didn't even have a referral, and he he took me in as a patient. Oftentimes you go to specialists, they need you to come with a referral. So who is Dr. Pottinger? Now, Dr. Pottinger received a BSc in tropical agriculture back in 1982 from UA St. Augustine. So he's originally from Jamaica and he came to Trinidad for school. After working as a farmer for 2 years, and I think he still does some farming in Trinidad, he started his medical degree at Mona in 1984 and received his bachelor's degree in medicine and surgery. He then worked in various departments in Trinidad, particularly obstetrician and gynae general surgery for about 5 years. In 1994, he migrated to the UK and obtained membership into the Royal College of Obstetrics and Gynecology in May 1996. He then worked on various gynae oncology departments in Liverpool, UK for 2 years before spending his last 2 years in the UK at the Queen Elizabeth Hospital, Newcastle, as a specialist in gynae oncology. The gynae oncology is that area of gynecology that specializes in cancer. Since 2000, he has worked privately as a consultant in gynae oncologist in Trinidad and Tobago. He was awarded membership of the British Society for Colposcopy and Cervical Pathology in 1998. These are some big words. Doc will talk to you a little bit more about this, right? He was awarded membership. He was accepted as well as a member of the International Gynecology Cancer Society in 1999. He was accepted as a member of the European Society of Gynecology Oncology in 2002 and obtained membership of the American Society for Colposcopy and Cervical Pathology in 2004. And he was again admitted at the Royal College of Obstetrics and Gynecology in 2008. And he obtained his membership of the Caribbean Gynae Oncology Society in 2016. Welcome, Dr. Pottinger. That was a mouthful in talking about who you are and your specialty. I recall when I first mentioned that I wanted to have a conversation based on some stuff that I learned from you that I thought, all these decades I've been on Earth that I didn't know about them. So I thought it would be helpful to impart some knowledge to many of our women who need to have, that kind of knowledge from someone who is open and ready to talk about things even outside of the medical sphere, like the holistic side of things. So Doc embraces also the holistic side of his field. So welcome to Dr. Pottinger. So today it would be, I'll be asking Dr. Pottinger some questions. I'm not sure if we'll have enough time, but you can jot your questions in the chat if you would like to as we go along. We may be able to spotlight a few people to have some conversations. In the meantime, I'd like everybody to mute whilst we're on this call. So Dr. Pottinger, I'm going to hand over to you to, share some insights into your experience, your expertise, and particularly related to this topic, gynecology and cervical cancer. So cervical cancer is one topic outside of the larger gynecology topic. To give the viewer some insights into who you are and, get the conversation going.
You hearing me?
Yes, we're hearing you
All
well.
right.
And I'd
All
like to
right.
say Doc is very busy, extremely busy. He was in the hospital not long ago, and he came on to do this call with me. So thank you, Doc. I appreciate
All
it.
right. Okay, cool. So a gynecologist is somebody is a gynecologist who subspecializes in gynecological cancers. And the gynecological cancers start from outside. Everything you can see on the outside is called the vulva. And then above the vulva is the vagina. At the top of the vagina is the mouth of the womb, which is called the cervix, or the neck of the womb. It says cervical, it means the same thing. The cervical spine means the bones in your neck. So it means the neck, or most people say the mouth. Above the cervix is the body of the womb, which is called the corpus. That is where babies and things develop in. Attached to the corpus are two tubes called the fallopian tubes, or the oviducts. And near to both of those are two glands called the ovaries. And the ovaries produce the eggs that can be fertilized by a sperm and then develop into a baby. And the ovaries also produce some chemicals called hormones, very important. Testosterone, progesterone, estrogen, and some other things too. And then the lining inside the pelvis is called the peritoneum. So from the peritoneum right down to the vulva come under my area of expertise with respect to gynecology. Now the cervix, cervical cancer, presently is second to breast cancer in Trinidad, in terms of incidence and also in terms of killing women from cancers. And some parts of the Caribbean, it might have been changing, but I know in St. Vincent, it used to be number one. I think in Jamaica is also number two.
Wow.
Right. So it is a tragedy in the sense that almost all cervical cancers are potentially preventable. Now, over the last about 30 years, we now know that almost all cervical cancer is due to a viral infection, a persistent viral infection with a family of viruses called the human papilloma virus. Well over 100 of them have been isolated so far, and 30 of them infect the genitoanal region, and 14 of those are called oncogenic viruses, meaning that they could cause cancers. However, the top four is responsible for like 90% of the cancers, and the top eight like nearly 98, 99%. So the most important one is something called HPV 16 and then HPV 18. Those two, most parts of the world responsible for about 70% of the cancers. After those, then it's 45, 31, and you have some, like 35, 52, 58. These are the most important ones. Not important for we get into all of that, or even to be tested. The important thing is that we now know that almost all invasive cervical cancer is due to a persistent HPV infection. So it is now stated that the necessary cause for cervical cancer is a persistent infection with one of the oncogenic HPV viruses. And the two most important one is 16 and 18. Cervical cancer, like in the States, used to be the leading cause of death for women from cancers before, before about 1940. In 1928, there's a doctor by the name of George Papanicolaou who devised a means of sampling the cells from the mouth of the womb, which is the cervix, and putting it onto a slide. And then you spray something called a fixative on it, and then you can stain it with certain stains, and then examine the slide under the microscope at high magnification, looking for telltale signs of the virus or early changes in the cells that can lead to cancer eventually. That was in 1928. This was discovered, and then when it was initiated in the States as a regular screening modality by about 1940, then cervical cancer started to plummet. Of more recent vintages in the UK, cervical cancer was very rampant. And in 1988, they initiated an organized cervical cancer screening program, which they call the Call and Recall. In the UK, wherever you are, whether it be Scotland, Wales, England, wherever, you have to register with a general practitioner. And the general practitioner is linked to like where you was living before, so your information is sent to him. So in England, every 3 years, somebody will get a notification that their pap smear is due. And since 1988, they gave incentive to the GPs, meaning that they get paid an additional amount of funds. When I left, it was about $105 for every person who they do a pap smear on. So the uptake was, it was very rapid, to the point where once they hit 70% of the sexually active women being screened on a 3 yearly basis, they start to see a rapid decline in the incidence of invasive cervical cancer. No, no third world or developing country has been able to reproduce that, primarily because of manpower, money, equipment, and things like that. I think Costa Rica was the only so-called third world country that came closest to replicating that. So in Trinidad, where I am living, there's not an organized cervical cancer screening program like that. What we have here is an opportunistic screening, meaning the woman might come into her GP and ask for a pap smear, or gynecologist, or she might go to family planning or cancer society and ask for a pap smear. And it tends to be the same woman who go to more than one point. They might go to family planning, and they go to the GP, and they go to the gynecologist, and they might go to the cancer society. So some people are almost being over-screened, and then the vast majority of the population not being screened. I was looking at some numbers early this morning pertaining to Trinidad, and I think in 2019, they were saying that they did a survey, and the question was asked, have you ever had a pap smear? And somewhere about 65% of the women said yes. And when they say, have you had a pap smear within the last 5 years, it was like 55%. And if you have a pap smear within the last 3 years, I think like 45% answer. Now, personally, I find those numbers sounding quite high. These were probably it was not big sample and across the country. So like, for instance, if somebody come and sample my population, my patients, the numbers might even be higher, because my patients are educated and they understand the importance of doing the pap smear on a 3 yearly basis. Whereas I'm regularly seeing people who walk into the office with full-blown invasive cervical cancer, postcoital bleeding, intermenstrual bleeding, bloody, offensive, smelly discharge, and oftentimes, they never had a pap smear, or had one pap smear 20, 30 years ago. So the population in Trinidad is grossly under-screened. And the same thing applies to the rest of the Caribbean. In fact, Trinidad might be one of the better places in terms of the numbers of people being screened. Now, the pap smear, for a screening test to be effective, it needs to be very sensitive. Sensitive means that if something is wrong, then the test should be able to pick it up somewhere above 70%. With the pap smear screening, the sensitivity is more like about 50%. So it's almost like flipping a coin. However, it's not so detrimental with the cervical cancer, because what is called the pathophysiology is very slow. So from the time of infection with the virus to the time somebody will develop a cancer is very long, 10, 15, 20, 30, 40 years it can take. Wow. So if you do the pap smear now and it say that it is normal and it was wrong, that is called a false negative. It's not like you're dropping off a precipice, because if you should repeat it in 3 years. If you do it in 3 years, most likely you will pick up something. If in 3 years it's saying normal again and it was again wrong, it was another false negative, it's still not a big problem, because if you do it 3 years after that, you'll most likely pick it up. So because the pathophysiology is slow, it gives us a good chance, if we do the pap smear on a 3 yearly basis, to pick up pre-cancer changes. Right. No, we don't want to diagnose cancer, because if you diagnose cancer, the horse already bolt. And the management of cervical cancer is very expensive. Surgery is very expensive, chemotherapy expensive, radiotherapy very expensive. And regardless of what you do, if people present too late, it will still kill those people. So when you present with stage 3 and 4 cervical cancer, even with good treatment, the chance of dying is significant. So the thing is, because this cancer is so slow moving, and the pre-cancer stage is there for so long, it gives us a good opportunity to pick it up from screening. Now, the pap smear was the first screening. Over time, you have had different things develop. All right, they try to do things that not even as cumbersome as the pap smear, like something called villi and via. That just means you paint the cervix with certain chemicals, something called Lugel's iodine, and that is called villi. And if the cancer cells or the precancer cells will look different from the normal cells. And just inspection with your eye or on a magnification. And then you could also paint the cervix to something called Lugel's iodine, that is VIA, acetic acid rather, that is called VIA, visual inspection acetic acid. And the cancer cells tend to look white, right? With just normal eye inspection or with magnification. So for people who, like, say, living in the Amazon, some far place, have electricity and different other things, and all the different things we have to do, like, for instance, microscope and stuff, we deal with the pap smear. Those modalities have been shown to be effective, cheap, and effective. They used to use this significantly all over India, and we know that they work. However, in the Caribbean, I used to mention it when I just came back almost 25 years ago, and nobody was really interested, because we were into the pap smear. I want to go now more to the more advanced, technically advanced things. So after it was discovered that cervical cancer is due to a persistent infection with a high risk HPV, they started to do research into developing vaccines against the virus. Once we identified a virus is the cause, if you could get effective vaccine that is safe against it, then that could be like, nirvana. That could be the holy grail. In that situation, there's a potential to totally eradicate cervical cancer. And for the last 20 years or so now, we have some good vaccines, right? There's one called Cervarix, or they used to call it the bivalent vaccine, and that was developed in Belgium. And then you have one called Gardasil, that was a quadrivalent vaccine, and that was from Merck Sharp and Dohme from America. No, I don't want to get into the technical differences between the two. There are many, but this is not a medical doctor talk per se. All
Yeah.
right.
Doc, I have a question for you.
Yeah.
As you're talking about the screening, which is part of prevention, so there is the pap smear, and there is the HPVs. Is the HPV test different from the pap smear? You do a pap smear to determine if you have HPV, and what
All right.
age should
Yes,
one
yes.
start?
So since we discover now that that HPV is the de facto cause of cervical cancer, you could also try to screen, for precancer by checking for HPV. So there's a pap smear that was developed called liquid-based cytology, where you actually, apart from collecting the cells to put on the slide, you also collect fluid from the cervix and put into a container, whereby you could then send it to the lab, and they will check to see if you have HPV, or you could even check to see which HPV you have. Because if you have 16 and 18, or 45, or 31, or 35, or 52, or 58, all of those are considered high-risk HPV. Now, most people who have HPV will not go on to get cancer. It should be considered that everybody who have ever been sexually active have been exposed to HPV. There's a figure of say over a woman's lifetime, 80% will be infected with HPV. I don't like to say that figure because some people will always believe that they in the 20%, so they don't have to check. So I like to tell people that everybody who's sexually active, man and woman, have been exposed to HPV. About 90% of the people will have an immune system that will clear it, usually under 24 months, within 2 years. You have a small group of people, probably 10% or less, that have an immune system that handicap in some way that it cannot clear the HPV. So these are the people who are at high risk because they end up with a persistent HPV infection. And if those people negligent and not screening, either by doing the pap smear or checking for the HPV or do the VR, the VILI or anything, these are the ones that if they have a HPV infection there for 10 years, 15, 20 years, the virus do what it does and then they can present with invasive cervical cancer. Let me just explain. So when you get the virus life cycle is in the surface of the cervix, which is called the mucosa. So this virus don't go into the bloodstream like say measles, mumps, rubella, chickenpox, and all them thing and go all over your body. So the whole life cycle is just within the surface of the mucosa. It could be in your mouth, in your anus, and the penis, and the vulva, in the vagina, or the cervix. But the cervix is the main target. A part of the cervix called the transformation zone. So if the virus stayed there long enough and you didn't do your pap smear, at least on a 3-yearly basis, to know that it is there, or to pick up the early changes, right, then you are at risk for cervical cancer. So some of the early changes is something we call, you might say, mild dysplasia or mild dyskaryosis, or you see the term CIN1. CIN means cervical intraepithelial neoplasia grade 1. It means that if you cut a section through the mucosa, the cervix, the surface of the cervix, the bottom 1/3 of the cells that infected with the virus and looking to start the malignant change. If you just have CIN1 and the pap smear might report and say you have a low-grade squamous intraepithelial lesion, left without any management, only about 1% of those people, it will persist and migrate to CIN2, CIN3, and eventually can become an invasive cancer. Now, so they call that, we now know that that is not a real precancer lesion, so that is now called a low-grade squamous intraepithelial lesion. So if you do a pap smear and you say it is reported low SIL, mean low-grade squamous intraepithelial lesion, that is reassuring. That is not a big frightening thing to say that you going to transition to cancer anytime soon. So I normally reassure the people that what they have there is not a real precancer lesion, and tell them that we should repeat the pap smear in 6 months. If you repeat it in 6 months and it's still showing low SIL, reassure them again and repeat in 6 months. So because I said most people will clear HPV under 24 months. So once it don't jump to a higher grade lesion, what they call CIN2, CIN3, or nowadays they call it high grade squamous interepithelial lesion, is not a big problem. All right? So you still, well, it used to happen very commonly in the past. Even myself felt the need to want to treat people if they have a low-grade squamous intraepithelial lesion, or what we call CIN1, but it really is not necessary because it is most of the time that will disappear by itself. The immune system will eventually clear it. If you do a pap smear and it come back saying you have a high-grade lesion, all right, or what called CIN2 or CIN3, that need more follow-up. Most of the people who even have a high-grade lesion will never go on to get cancer. But we do have any definitive thing to tell who will go on to cancer and who will not go on to cancer. So we have to follow it up. So one of the things now with the liquid-based cytology is that you do the cytology and you also have the liquid that you could check to see which HPV the person has. So if the person have HPV 16 or 18 and the pap smear is normal, you still don't have to go and treat because you can just educate them that you have a high-risk HPV, but presently it is not causing a precancer lesion, but they will need to be followed up. All right. Most of the times, I hope I'm not getting too technical. You following what I'm saying?
Yeah, you can only follow. Let me ask you a question though.
Yeah.
You mentioned males when you were talking about the HPV as well. Are you saying males get HPV? And where does where does the cancer really emanate from? Where does it all start? So
All right.
is it male
Everybody is
giving
sexually,
females or
yeah.
what?
All right. We don't want to blame anybody. So we'd have to go back right back to time immemorial to see where it come from first. But right
Okay.
now in the human population. So if a man have sex with a woman who have so HPV, she could transmit it to the man. If
Mm,
that man no go and have sex with another lady who don't have it, he could transmit it to she. Right.
mm,
So it's a sexually transmitted thing. All right. The thing is, men can get cancers from it too, but far less frequency than with the woman with the cervix or the vagina or the vulva. So it's the same HPV could cause cancers of your penis and your scrotum. And
mm.
those who have anal sex, almost all are anal cancer in both men and women is due to HPV. Right. People having oral sex, you can get it in your mouth. And if you have an immune system that can't clear it, you're at risk over time that you could develop a cancer of your lip, your tongue, your larynx, or wherever that is HPV related. But those are very rare compared to the cervix. So for all intents and purposes, we're talking about the cervix. Now, I jump in all over the place because so
But
much thing.
another question for you. Do women need to have symptoms? Okay, so we know we're supposed to do our pap smears, right? But in the event you don't, are there any signs that you should look out for?
We
Uh,
don't want to wait for the signs because when you have the HPV, dear, it is an
mm,
asymptomatic thing. It don't cause any problem. The only time you're going to start to have a sign is when it become a full-blown cancer. Let me just try to explain what is a pre-cancer versus an invasive cancer. So as I was saying before, the life cycle of the virus is within the mucosa. The bottom one third, if it have the virus and it changes, it's called CIN1. If it go up to two-thirds, it's called CIN2. If it go up to the last layer, the full thickness is because CIN3, or they used to say carcinoma in situ. Even CIN3 is only about 30% to 50% of the time that will then break through. Like the top of the table here is a foundation called the basement membrane. So the on top of the basement membrane is the mucosa that have the changes. So even when the full thickness of the mucosa of the cancer changes, is only if it then break through the table, which is the basement membrane, and get below the table, then it become an invasive cancer. So even if you have carcinoma in situ or CIN3, that can't go anywhere and kill you because the mucosa don't have any blood vessels or any lymphatic channels that it can go into and spread. It will just stay there. Some people will clear it and it could just, some people just stay right there and don't go no more. And about 30 to maximum 50% of the time, it could break through the basement membrane, which is the top of the table, and get below the table, and that is when it becomes an invasive cancer. Because below the table, you have lymphatic channels and blood vessels. It could get into the lymphatic channels and then spread to your pelvic lymph nodes and elsewhere. Or if it gets into a blood vessel, it can then spread to any part of your body. It can go to bone, it can go to your lungs, your liver, etc. And we don't want that. It rarely spread by blood, however. Now, if somebody do the pap smear. You should start doing pap smear, I believe. Well, my policy is I tell people to start by 3 years after sexual debut, right? Like in Trinidad, you see the Ministry of Health criterion will say you start at 21. I don't like that because I've had people with cervical cancer at 21. So
oh,
say, for instance, somebody became sexually active at the age of 10 or 12. I encourage, if you said 3 years, by 50 or so, they will start doing the pap smear. In the first 2 or 3 annual ones are normal. You don't need to continue doing it every year. It should be done every 3 years. And the 3 year interval is just about optimal to pick up things if any change is taking place. Say somebody have been doing a pap smear all their life and they reach 50, 55 and never had an abnormal pap smear. It means that person immune system most likely is one of them that can deal with the virus. So those people, you could lengthen the interval to 5 yearly. And I have many patients who I tell them 5 years. I don't want to see you in 3 years because you have had umpteen pap smear, all of them normal. That means your immune system dealing with it. However, as we grow older, the immune system change because the immune system at its zenith in adolescence. After about age 15, is downhill for the rest of your life. So somebody who got the virus in their teens and clearing it, 20s and clearing it, 30s and clearing it, 40s and clearing it. May read 50, 60, 70 going down the road and get another virus and can't clear it. Now, the problem with this, as I was trying to say before, is not like measles, mumps, rubella, and chickenpox. Those things, if they don't kill you the first time, you virtually never get them again because your immune system, what we call the reticular endothelial system, will develop memory. So they have some cells called memory cells for those things that circulate in your system for the rest of your life. So the next time mom show up, or measles show up, if you were vaccinated or if you survive being infected, you will have memory cells that will recognize the virus and it becomes something called a plasma cell and boost the antibody response and neutralize the virus and protect you. That don't happen with the HPV. So the HPV is a what they call an innate immunity. It's like an acute inflammatory response that will clear it, usually by 24 months, but you don't develop no memory because the virus didn't go into your bloodstream. It didn't get exposed to your bone marrow or your spleen or your thymus or your liver or any other places where you have the reticular endothelial system that should process it and develop memory cells. So somebody could get the virus 10 times, 20 times, 30 times and clear it all the time, but they're still susceptible. So that piece of information is important for people to understand that even though you get it already and thing and so, and it didn't cause no problem, as you grow older and the immune system wane, you might reach to a point in your future where you get a virus and your immune system can't clear it. And if you're not doing your pap smears, then you might be one of them that will come down with signs and symptoms and then have invasive cancer, which is very difficult to manage. That was clear, Donna. You understand that?
Yes, yes, Doc. I hope the audience, if you, we may, some people will ask some questions. We'll try and fit them in. And someone
I was
also will
kind of
share
trying
their
to let them go
story.
along, because it's so much thing to say. If I just start it to be one big monologue and I'll be talking the whole day
No, no,
because it's
no, no. So we're
to
gonna
say.
ask, yeah, we're gonna bring the questions in.
All right, so maybe just touch one more thing in
Yes, okay.
screening.
Yeah.
You could screen by just using HPV. So like in India, they were doing like rural areas. They had some kits where the woman could put like a fluid in the vagina and have a brush that they swill around in the upper vagina and the cervix and then put it into a canister and break it off. And then they could ship it off to the lab miles and miles away. So that is called self um, sampling, and it worked because some of the people embarrassed to come in to doctor and to go and stir up and to put in speculum and to do like the pap smear. So when the HPV came along, you could have self-sampling with the HPV, and it was found to be better than the pap smear actually. So if HPV there, pick it up greater than 70%, and then some places you could then test what HPV because you have high risk and low risk. And if the person have a high risk HPV, that is the type of person where you'd have to call them in for surveillance. There is something that is called a colposcope. It is just a microscope that you put in something called a speculum to open the vagina so you can see the cervix. Then you use a microscope and a magnification 5 times, 8 times, 10 times as the case may be. So you see with much more detail. And the same Lugol's iodine or acetic acid, you paint it onto the cervix and looking under the microscope, if there is CIN1, 2, or 3 there, you're going to see certain changes develop on the cervix under the microscope. So say somebody was sent to me because they had a pap smear that suggests they had a high risk HPV, and the pap smear said that they have a high grade lesion. They are, what I will do is colposcope them with this microscope and then paint the cervix. And if any of the high grade lesions turn up, is a one-stop shop. I would inject the cervix with local anesthetic and then remove the parts of the cervix like a loop. They call it a cone, like a loop cone. With the person will be hooked up to a machine called a loop diathermy machine and remove the abnormal piece and send that to the pathologist. So it is a diagnostic and treatment in one. But
Okay.
that is very specialized. Is not many doctors trained to do this or have the equipment to do this. But anybody who is like a gynecologist or even somebody the more experienced gynecologist, I think set up to do this. So you could move from high grade pap smear to colposcopy, and I don't take punch biopsies, and so I and to send to the lab, and then the pathologist every time say, oh, she have CIN1 and 2, then she have to come back for the treatment thing, right? I am very confident in my diagnosis from the colposcopy, and I just treat them one time. And I've picked up hundreds, if not thousands, over the last 25 years of people with early stage, right? You might have CIN2, CIN3, or even very early stage of invasive cancer, what we call 1A1, and that treatment is the treatment for it.
So, Doc, I have another question for you.
Yeah.
Someone wants to know, their grandmother died from cervical cancer. Is it something that's genetic?
No, the short answer to that is no, because as I was saying to you, it's not simple. It's not simple yes or no. It's a little bit more nuanced. But if I had to say yes or no, I'd say no. This is not one of those things that we have like a mutation and that the family might have the thing. However, if your mother had died of cervical cancer and your grandmother died of cervical cancer, your auntie died of cervical cancer, probably these people inherit some kind of mutation in their immune system that their immune system handicap and can't clear it, right? So this person should, nowadays, they should get themselves vaccinated, and they should definitely be doing their pap smear every 3 years. But
Right.
if I had to answer if this is a familial or genetically thing, I would say no.
Okay, so we want to discuss a little bit about the vaccine. Can you in Trinidad and even Jamaica, because we have people from Jamaica here as well, from all over. Can you just walk into a facility and get the vaccine? Also, are there side effects? Can you
All right.
tell a little bit more about the vaccine?
In
And how
Trinidad,
costly is it?
yeah, in Trinidad, Gardasil was available from 2006, and it was only available privately, and it costs like about 1,500 TT dollars to give you the vaccine. And at that time, um, you used to have 3 doses. So if you get 1 dose now, that is called 0, then you'd give the second one 2 months after, and then the third one would be 4 months after the second one. So that is called according to protocol for Gardasil. So you get the 3 of them within 6 months. All right. Then in 2009, Cervarix, which is the bivalent vaccine, was then available in Trinidad privately. So that is the one I mainly use, right? Because in many respects, it's better than the Gardasil. But that one now, if you give a shot now, you give the second one 1 month after, and then the third one 5 months after that. So same 6 months, 1 month, 0 month, 1 month, and 6 months. That is called according to protocol from the studies. But in the studies, some people didn't get it like this. So some got 2 shots 6 months apart, or they got the 3 shots, but it's spread out over 10 months. So they still analyze those people. They call that now intention to treat, not according to protocol. And the intention to treat cohort was almost equally protected as the according to protocol people. You following what I'm saying here?
Yeah, yeah.
All right. And after time, plenty work mainly out of India and Mexico, because the vaccines are expensive. So they were trying to see if we could reduce the amount of shots. So with the children under 15, because we know their immune system so much more powerful and you get a better response, they started to give them 2 shots. So like they get one now and the next one 6 months after. And the children under 15 provide high levels of antibodies to the 2 shots, better than the older women who got 3 shots. So then it was changed somewhere around 2012, 2013, that the those below 15 only need 2 shots. And it's reaching to a point now where they're looking at if those can only have 1 shot, and if the 1 shot give equivalent protection to the 2 shot. So it may go to a 1 shot thing eventually. The safety is very safe, very safe. I myself vaccinated with Cervarix 2. I do have no cervix, but I have penis, I have a scrotum, I have lip, tongue, throat, and all those kind of things. And I don't want to be a carrier for anybody. So And from long time I knew, because I was going to the conferences where you're interacting with the scientists, them who developing the things, epidemiologists, virologists, etc. And I was saying it here that when it was in 2013, the government in Trinidad decided to start to provide the Gardasil through the public health system. So from '06, it was just private. But in 2013, it came into the public health and they choose Gardasil over Cervarix. So Gardasil has been available in Trinidad for the public since 2013. But initially, they said only girls below 12 could get it, which was a mistake. I know it was a mistake, but people don't listen to me. Boys should get it too. Girls should get it. And the studies with Gardasil went up to age 45. So from dealing with the cutting edge people internationally, I knew that we should be vaccinating people up to age 45. Nobody was listening. After a while, it then changed now that up to age 26 will go to a health center or hospital and so and ask for it and they will get it. Now, earlier this year, I had patients over 26 who needed to get the vaccine and I actually write a note on one of my letter pads, sending them to the local health center. And when they go to the local health center, they refuse to give them because the cutoff is 26. Wow. And to me, that is so much nonsense because cervical cancer is very high in Trinidad and the uptake, the voluntary uptake of the vaccine is very poor. I was looking at some numbers. It was introduced in 2013 and in 2021, the people who got the full vaccination, the according to protocol, was like 8%. In terms of those who had one shot, it was like 19%. So the vast majority of the at-risk population in Trinidad has not taken the opportunity to go and get themselves vaccinated. And it's expensive.
But I don't
One
think
of the
there's much
problems behind
PR
that,
around.
any country that introduced the vaccine without a 1 or preferably 2 years massive education program through Ministry of Health and Ministry of Education, so that people realize that this is safe. We're not encouraging promiscuity or whatever, and so on. That this is a good thing for your children, right? That wasn't done in Trinidad, so the uptake is poor and continues to be poor. And then you compound it by having people in the system that will reject somebody who come because they're over 26 years old.
Wow. Because I was just going to say that I haven't really heard any PR around this, encouraging you to get
No,
your.
to tell you the truth, the Minister of Health is always talking about your flu shot and flu shot. And you see how big they were on the COVID shot and thing and so. And HPV killing people in Trinidad every month, far more than flu.
Even though
And
yellow
I, I,
fever.
I have never heard they pushing the HPV vaccine in the way that it should, right? The rest of the Caribbean, I'm not sure. I don't even think even in Jamaica it is provided publicly. People would have to access it privately. Now, because there was some shortcoming with Gardasil, the Merck Sharp and Dohme, which is the company that produced Gardasil, come out with another vaccine, which like in America, this is the one that available. It's called Gardasil 9. The original Gardasil had 4 what you call virus-like particles, HPV 6 and HPV 11, which are the ones that most responsible for vulval warts. Those don't cause cancer. And it also has 16 and 18, which are the 2 most prevalent one in cancers. Up to 70% of the cancers have those 2. The Cervarix only had HPV 16 and 18, but it have a better adjuvant. The adjuvant is something that boosts the antibody response. It have a better adjuvant than the Gardasil, so it produces much higher titers of antibodies and a better quality antibody. The Gardasil generate more what you call non-specific antibodies, whereas the Cervarix generate more specific antibodies are called neutralizing antibodies that will seek out and neutralize the virus. All right, be that as it may, we have a better one now, which is called Gardasil 9, but as far as I know, it is not yet in the public sector, but you can get it privately in Trinidad. The rest of the Caribbean, I think people would just have to access the vaccines privately from the doctor. No, with the anti-vax thing and all that kind of thing, even here in Trinidad, plenty people don't want to take the vaccine because they're buying into the anti-vax nonsense. But this is one of the things that have been proven. In 2007 in Australia, they decided to go full, right, providing this thing publicly. And since 2007 to now, is like cervical cancer disappearing in Australia. And they vaccinated both men and women. Because if you vaccinate the men too, they can't be a carrier for a woman. Right. And plus, they've been protected too against anal cancer, penile cancer, lip, tongue, and throat cancer.
Yeah, I see someone mentioning here that the ministry is actually going to schools and giving the vaccine. She said they were in her son's school last week.
Yeah,
So
but the uptake is very poor. I know the uptake is very poor. When it came here first, I used to be on radio and TV almost 2 times, 3 times a week and trying to educating people about this, that this is a good thing. It is safe. And you should do it for your, it's one of the best things you could do for your daughter. And your son too, but primarily daughter, because they are the one. Cervical cancer is second only to breast cancer in killing women from cancer in Trinidad. And this is tragic, right? And for some, pap, if enough people was doing the pap smear, if over 70 to 80% of the population, that is the target, the sexual, the women from say age 14 up to say 65 then, we're doing the pap smear. If say we reach 70%, 80% of those women doing it, cervical cancer will take a big nosedive because most of the precancers would be picked up. But the rate at which people doing the pap smear is very poor. Those figures that I mentioned to you before, that's far too high. I am certain because from my practice I know anybody who I'm seeing for the first time, after I find out what the name and date of birth is, when was the last period, if I try to find out when they became sexually active and when was the last pap smear. And I'm telling you, it is very, very, very common that somebody will tell me they never had a pap smear or they had one 20 years ago, which is crazy.
yeah, someone is asking, does the birth control increase your risk of cervical cancer?
Well, this is something that always come up that the combined oral contraceptive pill increase the risk. But I don't like to talk about it because let me show you. If it increases the risk, is very minuscule. It come back down to having a virus and having an immune system that can't clear it, and negligence in not doing your pap smear and not taking the vaccine, which we have now. Because the benefits of the combined oral contraceptive pill are enormous in terms of protection against breast cancer, womb cancer, tube cancer, ovarian cancer, peritoneal cancers, all of the estrogen sensitive cancers, the pill protect you against. So to throw out all of that because of a potential very minuscule increased risk of cervical cancer, it don't make sense to me. Whereas we have screening modality, we have vaccine and all those things that will protect you against cervical cancer. You understand what I'm saying here?
Yeah.
Yes, so
Okay,
I don't like to push that argument, and it always come up.
okay, so it comes down to, I guess, practicing safe sex and
No,
doing.
all that safe sex argument, I'm not into it.
Oh, so it's a screening.
Because really and truly, it very to say to
Somebody
really
asked that if you use your
like
condom
people
all
will
the
say
time.
safe sex should mean that every time you using a condom
Right.
or you don't do oral or anything like that. But human beings are imperfect. So I don't get into that. So I tell people vaccinate yourself and do your pap smear. Those are the things that will make a big difference. And then there's a stigma attached to cervical cancer. It kind of going weird in a way now, but traditionally it was those women get it. Those women. Those women mean promiscuous women. So they start sexual activity very early, probably before 15, and they have dozens of partners, and they're not having safe sex, meaning they're not using condoms, and they have many children, and they get plenty of other sexually transmitted infections, so chlamydia and gonorrhea and syphilis and everything, and those are the women at risk. This is a red herring, right? I've had people, well, I like to tell this story. While I was in Newcastle, there was a lady came in, she was referred in because she was having offensive bloody discharge, and she was 33 years old, and she could not be examined outside, so they sent her to the cancer center. And her story was when she was 11, she was raped by one of her uncles. And it scarred her mentally to the point where she could never have sex again. She could not relax. She couldn't open her legs, not even for examination. We had to put her to sleep to examine her.
Hello.
And when we put her
Hello.
to sleep, um, something coming.
Hi.
You hearing me?
Yes, I hear you.
Who is that? Everybody's supposed to be muted. Who is that?
Let me finish this point. Let me
Yeah,
finish the point.
continue.
The point is, when we put her to sleep and examine her, she had a big cervical cancer. So this woman had one sexual contact 22 years before she presented with invasive cervical cancer. So saying that is people going looking for it is not a true thing. And I have many patients who had one partner or two partner over their lifetime and come down with cervical cancer. So the risk is being ever been sexually active, being a woman who have ever been sexually active, you should, that is your risk factor for cervical cancer. Start doing the pap smear by 3 years after sexual debut. Continue to do it 3 yearly. As I said before, when you reach 50, it could go to 5 yearly if you never had an abnormal pap smear. Now we have the vaccine. We should encourage the young people. In Trinidad, it is now up to age 26. I hope eventually they will carry to 45 because the evidence is very effective that it works. And especially those who have had a bad pap smear or had CIN2 or 3 or even had invasive cervical cancer, it's imperative that those people be vaccinated because their immune system don't tell us already that it cannot deal with the virus to the point where you develop a real precancer lesion or a cancer. So even so after that is treated and cured, these are the same people who will be more susceptible, and the older they get more susceptible because the immune system will wane. So those people have to be vaccinated to help protect them going forward. I've been singing this for nearly 20 years, even before the vaccines were here. And people, look at me like I'm a lunatic, and my mind was telling me that anybody who I had to treat with a loop cone biopsy or knife cone biopsy or with a hysterectomy or a radical hysterectomy, they must be vaccinated because they are the ones at higher risk to come down with something again. They are the ones at risk for say take out the uterus. They are at risk for vaginal cancer. You may have had something lurking there, so you still have to follow them up if they, with pap smears, and you still every now and then, at least once a year, I will continue to do what is called a vault smear for those who had cervical cancer. And after 5 years of negative ones, I will probably go back to 3 yearly, provided they were vaccinated. You understand what I just said there?
Yeah.
So the person probably wanted to ask a question.
Could, not sure who it was, if that person could raise their hand. Somebody's asking, how long should one get their pap smear done after it was abnormal? Well, I guess the
All right.
doctor
So
should
if
advise you, right?
somebody had an abnormal pap smear and then they had the follow-up, the colposcopy and loop biopsy show that they had CIN2 or CIN3, which are real precancer lesion, that person should ideally be vaccinated and also have another pap smear. In my practice, I repeat it in 6 months. If that one is normal, it done again another 6 months. So about 1 year from the time they had the loop biopsy. If that one is normal, it then go to annually for the next 4 years. So if all of those pap smear have been negative at 5 years, they go back to 3 yearly follow.
Okay. Okay, we have a lot of questions here. 1 second, Doc.
How long the program supposed to be?
We're supposed to end at 6:30, and
All
we
right.
need
So
to.
just question time then. If you have plenty of questions, make the questions come. And if
Yeah,
anything,
yeah,
we
yeah.
can do a
Okay,
second
okay.
one and it
Well,
because it's a lot of things.
somebody wanted to give a little testimony. Pinky, I'm trying to, where are the hands? Pinky, okay, so Doc, let me talk a little bit about treatment.
Okay.
Um, treatment and some of the myths and
All right.
management of all of
So
this,
the
right? What are
treatment,
some of the treatment options?
all right.
And
So treatment option will depend on the stage. So say
okay,
somebody did the pap smear and it show a high grade pap smear, and they come in and had the colposcopy, that is the microscopic examination, and it looked funny, and we do something called a loop biopsy. If it is only CIN2, which is not an invasive cancer, or CIN3, not an invasive cancer, and all the margins were clear and everything, that is the treatment. And that person should ideally be vaccinated. If they're under 45 years, I encourage that. And they should have the pap smear follow-up, just like I said. If after 5 years, they have had a next abnormal pap smear, they should go back to 3 yearly. If somebody at the earliest stages of invasive cancer, like what we call stage 1A1. Stage 1A1 mean that the basement membrane has been breached with the cancer cells, but it is less than 3 millimeter deep. In the past, they used to say less than 7 wide, but that was changed in 2018. So if it is less than 3 millimeter deep below the basement membrane, it's stage 1A1. If it is a young person who do have no children or anything like that, I would just treat that with the loop and follow them up and encourage them to try get pregnant rather than take out the uterus. If you, I will even treat stage 1A2, which means the invasion is between 3 millimeter to 5 millimeter deep. But that is coming off a higher risk now that it may have spread. But if the loop show that it is less than 5 millimeter deep and there is something called lymph vascular space is negative and all the margins is clear, that most likely is still there, not gone anywhere. And that person, I'll encourage them to try have children quickly, that in the event that anything happened down the road, they could lose the uterus. But those people, I would take out the insurance, strongly advise them to get themselves vaccinated if they're below 45 years. Now, if somebody have the next stage up, which is a stage 1B1, that is a gross cancer, but it less than 2 centimeters in size. If it's somebody who young again and don't have no children yet, you could do something called a radical trachelectomy. There's a technical thing, and this is not a surgical discussion with doctors, so I won't get into it. The radical trachelectomy you could do to and serve and save that person uterus, and hopefully they can get pregnant. I've done it several times, and we have people. One girl have had 2 pregnancies after that. Now, if it is a 1B2, meaning something now which is between 2 centimeters to 4 centimeters in size, that my standard operation for that is something called a type 3 radical hysterectomy. For the 1B1, and is somebody who don't want to get pregnant, or older person have them children already and things, and so they could have what is called a type 2 radical hysterectomy. I'm not going to get into the technical differences between a stage a type 1, a type 2, type 3, or type 4. Okay? Now, in Trinidad here, because the screening is not good and people tend to present late after they do all kind of other thing, bush and 19 oil and all kind of thing before they present. A lot of people will present with big tumors, with bleeding and badly infected. And sometimes CT scan or MRI scan will show that they already have a spread to lymph nodes and things. If somebody, the standard treatment for that, like coming out of the States or UK, or what would be under the guidelines to the Ministry of Health, would be to treat that person with something named concurrent chemoradiotherapy. You're treating them with what is called external beam radiotherapy, and once every week they will get a chemotherapy drug called cisplatinum, 40 or 50 milligrams of that, because it sensitizes the tissues to the radiation. Right. Now, because things don't move as fast as it should, somebody present like that and I send them to the National Radiotherapy Center down in St. James, things can drag out really, really slow. And because of how slow the amount of people who are converging on the National Cancer Center for treatment, things just move slow. An example is last year, September, I had to do a lady who had a big tumor and she had a more aggressive type. The commonest type of cervical cancer is called squamous cell. Somewhere between 70 to 80% is called a squamous cell. Then a more aggressive type is called an adenocarcinoma. So somewhere between around 15 to as much as 30%, depending on what part of the world, is an adenocarcinoma. Those develop now inside the canal. They are a little bit more difficult to diagnose. All right. And she had a big one and started to bleed. She was bleeding out. Once these things invade a blood vessel, you can bleed out quick. And her hemoglobin was like over 12 and bleed and drop down to like 7 in a short time period. If you don't do surgery on somebody like that, she's going to die. Because if you're going to refer now down to St. James, for her to get radiation and chemo and thing, it is so slow she'll bleed out to death. So I will do cancer And these big tumors in a situation like this, and especially when people have plenty lymph nodes or big lymph nodes, it's very difficult for the chemo and the radiation to sterilize a lymph node which is bigger than 2 centimeters. And I know this long time before I came back because we were doing this in the UK. So I will do aggressive surgery for locally advanced cancers, even as high as what we call stage 3C1. That means you have pelvic lymph nodes involved, and then they can get combination chemotherapy, then radiotherapy. And I have many people with as advanced as stage 3C1 who have been cured. Cured meaning 5 years without any recurrence.
Okay. So, Doc, someone is asking if before 45 years the patient wasn't advised to get the vaccination after having a conization, is that what you call it?
Yeah, she might have conization if it's
Done,
TIN2.
should a 49-year-old get vaccinated?
Well, you see, if we had the Cervarix, which is the one that not since COVID came, it's not available again. That is the one that the government didn't buy. The Cervarix, the studies with this go up to 55 years. So if somebody presented to me at 49 who have had cervical cancer or a real precancer lesion, I would still vaccinate them with Cervarix. But that's not available in Trinidad again over the last couple of years since COVID. So the only thing available now is Gardasil 9, and the studies with that go up to 45 years. So I do have no medical evidence work, but you do have no medical evidence that vaccinating somebody like this at 49 with the Gardasil 9, that it will make a big difference going forward.
So that was for Nicola. Hope that answered your question. And so, Doc, tell us what are some of the myths and misconceptions, right? That you wish more people would know the truth about.
All right. The first myth is the one I just mentioned, that people who get cervical cancer is those women who are looking for it. Multiple partners and all this kind of thing is not true. For the example I just showed you there. It should be considered so that nobody no fall through the crack, that once anybody ever sexually active, you're at risk. All right. So that is the main myth that I like to dispel. The next myth that I like to dispel is that, oh, once you had it already, it don't make sense being vaccinated because it's all over your body. That is not true. I don't explain already. The whole life cycle is within the mucosa, the surface of the cervix, and you don't develop no immunity to it. So if you don't develop no immunity to it, you're still susceptible even if you get it many times. So if you're under 45, I'd still beg you to go and get yourself vaccinated. Another myth is that people believe if they're celibate, then they don't have to be doing the pap smear. So somebody who was sexually active in their teens and 20s and thing, and they might reach 50 and they're celibate. No, those people should still continue doing their pap smears because they might have had a virus from their 16 and their immune system was keeping it in check. But as we grow older, the immune system wane, and that person might come to a point where the immune system cannot keep the virus in check. And just like chickenpox can reactivate and cause shingles when you reach 60 and 65 and 70, the same thing can happen with HPV. So somebody celibate 20 years and can still come down with cervical cancer. I've seen it many, many times. And so the Ministry of Health stopped screening people with pap smear at age 65. And I don't agree with it. I know that is nonsense. The screening should not stop. I've operated on people in the 90s, many in the 80s, many in the 70s, who weren't sexually active 10, 15, 20, 30 years and still come down with invasive cancer. Wow. So I encourage my patients, even after 65, to still do their pap smear once every 3 to 5 years. Because if something develops in there, you pick it up early, easy to treat.
Okay, what advice would you give to women who may be nervous or hesitant to get screened?
Well, I'd like to tell them that cervical cancer is preventable almost 100%, and it is second only to breast cancer in killing people. So I can't see why somebody would be so reluctant just to come and do a simple test, which is cheap. And sometimes you have people who have had children already. I mean, after somebody have children, you're in labor ward and you spread out and baby come out. Why should you be bashful to come to just get a speculum put inside and use a little brush to do the pap smear, right? And if you're younger than 45, please go and get vaccinated. But even the people who are vaccinated should still continue with the pap smear because the vaccine is not covering 100%. It's about 14 of the viruses could cause cancer. But the vaccine will cover, let's say it covered the top 4 very, very good. And it covered the next 4 okay. So it could cover you good against 8. You still have the other 6 that if you bad luck it, one of them could cause the problem where the vaccine won't protect you against, right? You have like HPV 56 and 68. Those responsible for less than 1%, like 0.3 or 0.6. But you might be the lucky one, the bad lucky one. So you should still continue doing the pap smear even though you're vaccinated.
Okay, someone is asking if you're trying to get pregnant, can you take the vaccine?
Yeah, you could take the vaccine if you're not pregnant. There's no evidence that it is dangerous in pregnancy, but by and large, because we don't know, we don't advise vaccinating somebody when they're pregnant. So if they need vaccination after they deliver, even when they're breastfeeding, that is safe. You could do it then. If it's somebody who just about to try to get pregnant, most people don't get pregnant overnight just like that. I would still give them the vaccine. So if they have the first 2, say Cervix, it's just you do it now and the next one is 1 month time. And then they get pregnant, you can wait because those 2 prime up the immune system. If it's Gardasil 9, you have one now and the next one 2 months time. Those are called primers. So they prime up the immune system and then the third one is really a booster. But that booster will work just as good if you give it 6 months down the road or 12 months down the road or 2 years down the road. You understand what I'm saying here?
Yes, yes.
So if somebody get pregnant after they get the first 2 shots, it's not a problem. They go through the pregnancy and after they deliver, have the third one. It worked just as good.
Okay. Can one develop HPV in the cervix if they use condoms all the time and also having oral sex? I think you did answer that as part.
Yes. So if you one of the very few people who are so disciplined that you use a barrier method all the time, you're probably lucky. But somebody might use their finger. So I use my finger somewhere just now, and some guys like that, probably later on in the night, I push my finger somewhere else, no condoms on the palm of my finger, right? And so you could transmit it by close contact, probably not even if so they're just rubbing up the vulva and getting the pleasure from clitoral stimulation and thing. It is possible that this close contact you could transmit HPV from the vulva.
Okay.
So the answer is yes, condoms will protect you big time, but it shouldn't be considered 100%.
So what are some of the lifestyle changes or habits that will help reduce the risk of cervical cancer, you think? Is it just about sex or is diet part of it?
All right, let me show you. So the thing like heavy smoking can handicap your immune system. So we know people who smoke heavy have a higher incidence or risk for developing invasive cancer. So you should really try to encourage people not to smoke. Not to start, or if they're smoking already, this is one more thing. Every cancer, from your lip to your anus, is increased with smoking. So it's one of the worst habits somebody could have. And cervical cancer is increased with smoking too. So the smoking cessation is definitely one of the things that I advise. I would not advise people to stop taking their combined oral contraceptive pill, right? Because the benefits are far, far, far greater than any potential downside. So somebody who taking the pill and the longer they take the pill is the bigger protection they get against all of the estrogen sensitive cancers. That is breast cancer, endometrial cancer, fallopian tube cancer, ovarian cancer, peritoneal cancer. All of those the pill protect against. So I would not be telling somebody stop the pill in order not to get cervical cancer. That is a nonsense argument. The more important thing is encourage them to do their pap smear and to be vaccinated.
Okay.
All right.
Somebody asked if a male can get cancer from having oral sex with a female who has the HPV virus.
Well, I don't answer that long time. Yes, that's why I vaccinated too. Because if you get HPV, especially one of the bad ones, HPV 16, HPV 18, HPV 45, and you bad luck if you have an immune system, say for instance, you immunocompromised. You have HIV and you're not taking your medication. So if you have AIDS, everything else is more rampant with you. If you have diabetes and things like that, which we know can suppress your immune system, those people have a higher risk. If somebody have kidney failure and are they had a transplant and they're having drugs to suppress the immune system so that the immune system don't reject the transplant, those people are immunocompromised. Their immune system don't work as well. So these people are at higher risk to any virus or bacteria. So in these people, they'll have higher risk. So a man could get lip cancer, tongue cancer, throat cancer, laryngeal cancer, which is due to HPV. Now, back in the past, when smoking and drinking was very prevalent, it was estimated that 80% of head and neck squamous cell cancer was due to heavy drinking and smoking, and only about 20% was HPV related. Now, with people realizing how dangerous those things are, so the smoking has decreased, drinking has decreased globally. You find that less cancers in the head and neck region is due to these modality. It dropped about 60%, but guess what? HPV take up the slack. So it's now estimated that about 40% are lip, tongue, and throat cancers, which is now due to HPV.
Wow, that's high. Okay, so this is our, I have a question around barriers, right, that women typically face. And mostly women here, and usually there are some barriers to accessing services. How can these be addressed? How would you advise women today so that we walk into a health center and
And let
see?
me show you. Talking about Trinidad, there are no real big barriers. If people want to access doing pap smear, if
Mm-hmm.
people want to access getting the vaccine, they can the vaccine if you're lower than 26 presently. I hope they eventually change it to carry it up to 45. If they go to the health center and ask for it, they will most likely get it. If people don't want to go to the health center because it might be waiting too long and think, if they go family planning, I used to do a session of family planning every Wednesday morning for many, many years. And I used to do umpteen pap smear there. People could, if they want a little bit more privacy and don't want to go family planning, they could go to the Cancer Society. The Cancer Society have a clinic on Rosalina Street in Woodbrook where you can get your pap smear there. You can go to your GP. All GPs trained to do pap smear. Go to your GP and ask them for the pap smear. It's not very expensive, right? And you can get it there. If you have a gynecologist, go to your gynecologist and ask for your pap smear. Hello, those with gynecologists, the gynecologist should, I think, would most likely encourage them to do the pap smear anyhow. In my practice, most of my patients have had their pap smear, right? And if somebody come and never had a pap smear, I usually try to do it on that initial visit. And if it's normal, I will tell them when to come back. If it's somebody young, I will advise them to get the vaccine and things like that. And if it's somebody who don't want to go to the health center for the vaccine, they might say, Doc, I want you to give me. Then I will order it, the Gardasil 9, and they will get it in my office.
Okay,
So
so fine in
there are
Trinidad,
no big
hear that?
barriers. If somebody wants it, screening or treatment, they will get it in Trinidad.
Okay, so in Trinidad, we're saying the barrier to accessing is quite low, so there shouldn't be any excuses to take care of our health. Are there any specific lifestyle factors such as diet, exercise, and so on that can influence
All right. So
women's risk
the
of
things,
developing the cancer?
yes, the healthier person, we have a healthier immune system that will more likely can clear the virus, any virus, not just HPV. So if people practice a healthy lifestyle, mean eat properly, right? The Trinidad diet is a very pro-inflammatory diet. That's why the obesity rate is so high, and the downstream plenty diabetes and plenty hypertension and things like that. So if people try to cut down on carbohydrates break down the GI tract break it down to something called glucose and fructose. Now, glucose is the main fuel for our metabolism. All right. Now, if you eat too much rice and flour and Irish potato, so that is the a Sunday dinner, right? It's a big plate of rice and it have macaroni pie over that side, and it have some bus up shot on this side, and then you're washing it down with a big glass of juice, a red solo. That's a very bad diet because the rice, the flour, and the Irish potato, chip all the time, or frying some trans oil and all them kind of thing is not good. So when you eat these things, within 2 hours, it is digested to glucose. So the blood sugar gone through the ceiling. And if your pancreas not working well, that can push up the insulin high enough to clear the glucose from the bloodstream and put it into the cell where it need to fuel up with metabolism. Then it could back up in the bloodstream. That's what we call type 2 diabetes. Some people might have type 1 diabetes. Around 10% of people who are diabetic have type 1. That is an autoimmune disease. That's our next talk. We must talk about autoimmune disease the next day. So their body producing antibodies against the beta islet cells in the pancreas that produce the insulin. So the antibodies kill the beta islet cells, so they cannot produce any insulin at all. So those people have to get insulin injections every day. 90% of the people have what is called type 2 diabetes, and that is a lifestyle thing. Eating and drinking simple carbohydrates and plenty sugar and not exercising. So everybody getting overweight or obese. So they're on a treadmill. This is called a metabolic syndrome. And you might hear term as insulin resistance syndrome. Polycystic ovary syndrome is a subset of the metabolic syndrome. It's part of the whole thing. All right. And these things will eventually, if you don't step off of the treadmill, you can get overweight. You have a high chance of developing type 2 diabetes, a high chance of developing hypertension and the stroke and the heart attack and everything that come with it. So these people, and a lot of people not getting enough sunlight because we sleeping in air condition, come out and going out with car in air condition, come out of the car, going to the elevator, and going to your office all day in air condition, and then repeat it when you're going home. So we hardly getting any sunlight. So you find some certain rays, wavelengths of light from the sun will catalyze reactions in the skin that produce vitamin D3. Now, vitamin D3 is like a hormone. It things in our body. So a lot of people walking around here who D3 deficient. So if you can't get enough sunlight, I would advise everybody to supplement with vitamin D3. And don't supplement with 500 or 1,000 international unit. Those things are too low. Those are the guidelines are too low because people worrying that you could get toxicity because vitamin D is a fat-soluble vitamin and it can accumulate. I personally use 6,000 international units of vitamin D every day, along with something else named K2, 200 micrograms. And when I feel a little snuffle like a sore throat or a little stuffy nose coming on, I carry the vitamin D3 up to 12,000 units a day. And within 3 days, it's usually a bath in a little thing that's coming on. Right? So if people could live a healthy life, meaning regular chronic exercise, low glycemic index diet, meat is good. Meat and fat and all them things that was demonized. We were now realizing that they demonize them without proper evidence. So meat break down to amino acids, which are we call in proteins, and the fats come down to fatty acids, and some of them are essential fatty acids that we need. So if people eat more like what them call a ketogenic diet, right, and less carbohydrate, I basically eat once a day now, right? So intermittent fasting and all those things is good. So regular chronic exercise, don't smoke, don't drink or drink. I would drink 2 beer or 2 Mackies so if my liming. But the big set of binge drinking, you get drunk and thing and so it's nonsense. And some people like they can't enjoy themselves until they get drunk. It's not good, right? And that damaging up the liver. They get something called acute fatty liver, and it's just a slow slide all the way down to cirrhosis of the liver and death, liver failure. So the lifestyle changes are eat what is called a ketogenic diet or a low glycemic index diet. If you have to have carbohydrates in your diet, it's better you have what is called complex carbohydrates. Any kind of ground provision except Irish potato, yam and cassava and sweet potato and breadfruit and green banana and all those things. Them have fiber, so it's more difficult to digest. So those things now you're eating to provide food for your microbiome. Trillions of organisms that live in your colon. That when we eat like green leafy vegetables, which we can digest, we do those the cell wall of cellulose. Cellulase to break it down. But pop choy and lettuce and cabbage and kale and all them things very good for us because when we eat them, those pass through the stomach, pass through your small bowel and get down into your large bowel where your trillions of organisms down there, you're feeding them so they break down the thing and release the nutrients to you and then take care of you because around 70% of our immune system is in the bowel, particularly the colon. So rather than drinking a lot of sweet drink and adding sugar to everything and condensed milk to everything, you're encouraging the bad bacteria to colonize your colon. Once you wipe that out, and I don't add sugar to nothing. So I drink in my tea here is just my tea bag with a cup of hot water, right? And try to minimize too much of the rice flour Irish potato. But I train plenty. I mean, I drink and smoke. Me not have my body mass index is 23, which is optimal. So I could tolerate some sugar if me have to go somewhere and eat a big plate of rice and somebody give me something sweet for drink or so. But the average person who doing this every day in, day in, day out, their immune system handicapped and they are more at risk for everything, including HPV, persistent infection, which can lead to cervical cancer.
Okay, thank you, Doc. So we only have about 6 minutes left. I think you provided a lot of information there. Thanks to Nicole, a friend of mine, who provided the resources. Somebody wanted to know where to find you. We told them you're at Good Health. I don't know if you need to tell us anything more about that. If people were to do they need
Well, I
referrals?
don't. All right, this fairly private, but you know doctors are really supposed to advertise.
Oh,
But
okay.
my office number at Good Health is 624-7514.
Okay.
So if you either call that number Monday to Friday between 9 to 2, the receptionist will be there and you will get an appointment.
Okay. I'm just going to open the chat for if anybody has a question for Doc, you can unmute yourself and ask. We won't have time for much, but if anybody wants to or give a testimony, I see someone here saying, Doc, that they were a patient of yours, they were stage 3, and you literally brought them back to life. So kudos for that there.
Thank you very much. I
Is
wonder if
that
somebody recent or somebody from before.
Tracian? I don't know if Tracian want to share her comment is in the chat. And I think Pinky had something as well. And we have people from all over, people from Antigua, Barbuda as well.
Well,
Anybody want to unmute and ask Doc a
you
question
can do this
before
again if
we
you want.
wrap up? Sorry,
You
what
can
was
do
that?
this again whenever you want.
Okay, Doc, thank you.
All right.
Anybody else have any questions for Dr. Pottinger that you'd like to ask?
Good afternoon. Hi, good afternoon.
Go
Good
ahead.
afternoon.
My son had 2 shots. Is it that you're supposed to have 3? Because
How old,
he's
how
17.
old is your son?
17.
He had the shots before he was 15?
No, he had late last year and the first
Okay.
one late last year and then the second one in January.
All right. So he should go and get the third one because the third one should have been 4 months after the second one. So it was January, so February, March, April, May. He should have it from May or June. But if you go and do it now, it will work just as good.
Okay, thank you.
All right.
Anybody else? Thanks for that question. I didn't get the name of the person.
Hi, good afternoon. What I want to know if someone have a hysterectomy, if they could still if they should still do pap smear.
Only if the hysterectomy was for a cancer or CIN2, CIN3, which are precancers. So if you had hysterectomy for fibroid or perimenopausal bleeding or something, and you were doing your pap smear and all them was normal, and when the pathologist checked your uterus, there was no evidence of viral infection or precancer lesion, then you don't need to do the pap smear. But somebody who had CIN2 or 3 or had invasive cancer, their immune system telling us it can't deal with it. So those people should continue to have what is called a vault smear, right, the top of the vagina, and should still do it 3 yearly and probably go to 5 yearly after 50, 55.
Okay. Someone is asking if
Thank
their
you.
son started the shots but didn't complete
What?
it. If their son started
Yeah.
the shots but didn't complete it, can he start over?
Well, if they get the first 2, say 1 month apart or 2 months apart, the immune system is already primed. and they will have antibodies there, but it won't go to the level that it need to go to until they have the third one. So if the son is over 15, they should go and get the third one. Even if it's 2-3 years ago, they had the first two. It will work just as good.
Okay, Kalisha, that's for you. Anybody else before we close? I need a minute to thank Doc.
Could you repeat the number, the phone number? Thanks.
The office number is 624-7514.
Thank you much.
And Doc, do you operate elsewhere? Like, do you go to Jamaica, and so on?
I slowing down now. When I came back, I used to go up and down the island. People used to come from the island, but I used to go like Barbados, St. Vincent, St. Lucia, and do the radical hysterectomies because I didn't have anybody up there that could do them. If they don't want to travel to come here. But now you have more people trained in the islands and things, so I don't have to go there again. And I turn in old now, so I have to wind up.
Okay. So, Dr. Pottinger, I really want to thank you from the bottom of my heart for this hour and a half. I thought it was really very important for us to start having these conversations. Some of the topics, some of the inside the conversation can be taboo and people don't want to talk about them, but it's the reality of what we live. And to help us, most of our women to get rid of the myths and the fear around doing our checks. You have to do your checks all the time. I'm glad to know that there are resources available. The barrier to get it access in Trinidad is quite low. I'm not so sure about the other countries, but if you're in Trinidad, please make the effort to go to the health center and these other places to get your screenings done and your vaccines done. And if you have children, make sure those children get their vaccines. Right. So
one more thing, Donna, before we go.
Yeah, I was gonna give you the last word. Yeah,
this was if this was recorded, it would be nice if you could get it to replay because a lot of important things are said here today.
Yes, it's been recorded. We went on Facebook, but a little bit late because we were getting that feedback. So I want to thank a friend of mine for sharing. Joella, it's 6:30. Quickly ask your questions so Doc can.
Yes, sorry about that. I just want to make sure how I'm in the US, but I want to make sure how to follow him. And I see two numbers, so I'm confused. Which one is the correct one?
The office number is 624-7514. And since you're outside of Trinidad, you have to put 1868 before that to call the office.
Right. Thank you.
247-514. Somebody could drop that for me. Oh, so thanks everybody for your time this evening. Somebody asked where they can follow Doc on social media. We'll have him again.
I'm not a social media person, really.
He's not a social media person. He's extremely busy. As I told you, he did an operation like a couple of days ago. This morning he was in the hospital. I'm like, Doc, are we still on? And he still found the time to bless us this evening. So thank you, Nicole, for sharing that. Thank you, Doc. Have a great rest of your week, everyone, every week ahead. To all the women, take care of yourself. And we encourage the men to make sure all the women in your family, they're being taken care of. And you are also taking your necessary precautions as well. Okay, thank you. Any final word for the people, Doc? It's yours.
I just want to encourage you to do this again, not on any topic you want to cover, we will deal with it.
Okay.
I don't want to brag and boast. There's not plenty things people can ask in my area that I can't deal with.
Yes. Okay.
So we can deal with probably ovarian cancer, fallopian tube cancer, endometrial cancer, or even breast cancer, any kind of cancer really. If you don't want to talk about colon cancer or prostate cancer or whatever, we can deal with it.
Okay. All right, no problem. We'll do that.
All right then, cool.
Thank you. Have a blessed week ahead, everybody. Thank you so much for your time. I truly appreciate it. Bye.